All right, good morning, everybody. My name is Dr. Isa Granados, and I'm a postdoctoral research fellow at the Center for Healthcare Delivery Science here at Nemours. I'm based in Jacksonville, Florida, and I'm really excited to be here. Unfortunately, our team meetings are always at 9 o'clock on Thursdays, so I always miss this, but I'm excited to connect and grateful to be sharing about my KO1 submission, which I submitted in June, and I was able to participate in the GIN's K writing group program, which was fantastic to keep me on track. But the topic of it is on the ripple effect of parental obesity medication treatment on family health behaviors and child outcomes. And so I'll share a little bit about my K, and I'm really open to feedback, discussion at the end. I'm working on a Nemours Fellows grant and then some other career development grants to sort of evolve this initial study idea and see what else is worth looking into. So a little bit of background first. Obesity remains a critical public health issue. It affects 40% of adults, 21% of children in the US, and has profound costs and implications on cardiovascular health, healthcare costs, and life expectancies. Among children, obesity is the leading risk factor for early onset hypertension, dyslipidemia, and other cardiometabolic conditions. And it's really important that prevention and early intervention is a priority. We also know that one of the strongest predictors of childhood obesity is parental obesity. Children with parents that have obesity are 4 times more likely to develop obesity themselves. However, it's important to note that parental weight loss is one of the strongest predictors of child weight loss. So that shows the pivotal role of parents in shaping family health. Obesity medications, particularly the new glucagon-like peptide-1 receptor agonists, or GLP-1s, have been transforming adult obesity care by promoting significant weight loss and behavior changes, such as reduced cravings, smaller portions, and healthier food choices. And these medications, while prescribed for the individual benefit, may alter broader household routines and create ripple effects on family-level health behaviors. However, the impact of the parental obesity medication treatment on child's diet, home food environment, and outcomes is not studied at all. And this is a critical gap in the intersection of adult obesity treatment and pediatric cardiovascular prevention. And for context, since I applied this grant to NHLBI, my outcomes, the way that I describe them, are cardiovascular prevention or cardiovascular outcomes. And so the goal of this K that I applied for is to develop the first empirical evidence on how parental obesity medication treatment influences family health behaviors and child outcomes, and to define these key behavioral mechanisms and targets for future intervention. This work is guided by the family ecological model and the orbit model, which I'll show in a later slide. And it'll be a sequential mixed method study using surveys, qualitative data, and electronic health record data to examine how pharmacologic treatment in adults and parents may influence child diet quality, the home food environment, and child cardiometabolic outcomes. And these insights will hopefully inform the development and design of a future R34 application to develop and pilot test an intervention that supports parents in extending the benefits of their obesity medication treatment and behavior change for the family. And so my central hypothesis is that parents using obesity medications on that treatment will have more positive changes in the household food environment compared to parents that are not on obesity medication treatment. So this is the family ecological model for family obesity, and it demonstrates how health behaviors are transmitted across generations. It emphasizes how parenting practices, family routines, and broader contextual factors shape child health and positions parents as the gatekeepers of the home environment. So the orbit model is another model that I'll be using, and it is a framework to help develop behavioral interventions. And so within the orbit model, this study is part of the phase 1A area, which is responsible for identifying mechanisms and targets for future interventions. And so this K that I'm proposing will lay the groundwork in the design phase for later an intervention or strategy to build on the behavioral momentum of parents using obesity medications. And so for this study, we'll recruit a total of 250 parent-child dyads from Nemours Children's Health electronic health record. And so for the 3 aims of this study, there will be a cohort that will be built. Half will be parents that use obesity medications and half will be parents that do not. We'll have to screen and survey for that. But for the children, they must be between the ages of 5 and 11. And the reason because children over the age of 12 may be eligible for obesity medication use, and also this younger age group is more influenced by their parents. The children will also have overweight or obesity. Their BMI will be over the 85th percentile. Then the parent must also have overweight or obesity and live with the child 50% or more of the time. We'll identify child patients that are eligible through the EHR, invite them to complete a screening to determine if they're eligible and whether they would go to the obesity medication treatment bucket or not. And so here's a little bit about our enrollment process. So all consenting parents will be enrolled in the cohort, and they'll be funneled through aim 1, 2, and 3, depending. The study is powered for aim 3, which will be 12-month outcomes, but for aim 1, 128 parents will complete surveys about the child diet, parent feeding behaviors, and other surveys like that. Aim 2 will be a smaller subset where we do interviews and conduct a video home food inventory to see what is in their home and compare amongst parents not on obesity medication treatment and those that are. And then aim 3 will look at 12-month outcomes of the children using electronic health record data. So aim 1 is to assess the differences in child diet between parent-child diets with and without parental obesity medication treatment. So there are several measures that we'll collect. This will be cross-sectional with 128 dyads. The main outcome variable is child diet quality, which will use the Healthy Eating Index to assess adherence to dietary recommendations. We'll also explore several secondary outcomes like childhood physical activity, parent feeding practices, etc. So enrolled patients will complete a baseline survey and REDCap, and that will include details about their obesity medication use as well. Parents will, like I mentioned, will be funneled into yes users or no. To measure child diet and HEI, we will use the 24-hour dietary recall assessment tool, which is the gold standard. It's very time intensive and requires 2 measures, one during the week and one during the weekend, but this is the preferred measure of the NIH and the most validated. And that will be part of my career development goal, is to learn how to do that. Let's see. Then child and parent factors will obtain child factors from the Nemours electronic health record, and parents will answer surveys about their demographic characteristics. So then for the analysis of the survey data, we'll do multivariable linear regression, looking at the association between parental obesity medication use and child diet quality, adjust for child and parents, covariates, and then we'll do secondary analyses on other diet-related outcomes and physical activity. We will be collecting more data on parent obesity medication use because depending on the dose and how long they've been on it, that might affect the impact on the behavior. So we'll collect, we'll do some sensitivity analyses on that. And so we were able to power this analysis for a medium effect. All right, so aim 2 is to explore parental perspectives on the impact of obesity medication use on the household food environment. And so to do that, we will draw on aim 1 survey data and proposively sample 25 to 30 parents balanced by obesity medication use and other sociodemographic factors. Interviews will focus on patterns of grocery shopping, meal preparation, feeding dynamics, and routines. And then parents will also complete the household food environment, which is a virtually guided tool to determine an obesogenic household score. These are, I'm hoping to inform the design of a future R1 and to provide context to the survey results. And so we'll use thematic analysis using the family ecological model for survey analysis. And then we can integrate aim 1 survey data on behaviors using a joint display approach to sort of to help understand what's happening and use the more in-depth information from the interviews to contextualize that. And lastly, aim 3 is to assess the association between parent obesity medication use and child health outcomes over 12 years. Specifically, we'll look at BMI outcomes, blood pressure, and lipid panel. We use triglycerides. And so this will be amongst the full cohort of 250 patients. And the data will be obtained through the Nemours electronic health record. So we won't need to ask the children any information about them. There will be a follow-up period. So there will be 1.5 months before and after the 12-month period to be able to see if they have outcome data. But we'll be able to calculate BMI, percent of the 95th, blood pressure, and triglyceride change over time. We can also use the survey data from aim 1 to look at different factors like dietary factors in the subset that participated as mediators or modifiers. So for this analysis, we're using a multivariable regression, adjusting for key covariates, and we'll explore different moderators like obesity medication type, adherence, and then mediators like diet and feeding. And we'll conduct some sensitivity analyses looking at variations in duration of obesity medication use, etc. Some potential challenges may be that only 6% of US adults are on obesity medications, supposedly. So we anticipate enrolling parents that are not on obesity medication use very quickly and then capping that and having to recruit longer for those patients. However, we do feel confident that we'll be able to get to our number of 250 total patients because we pulled a query from the Nemours electronic health record data, and there are over 13,000 patients eligible for the screening process of our study. Missing data and measurement limitations is also an issue. There may be self-report bias for the surveys on dietary intake and feeding practices, but we will use validated instruments, the gold standard instruments, and provide support for answering those surveys when needed. We'll also monitor missingness from the electronic health record and make sure to have a flexible follow-up window to help mitigate any gaps in the electronic health record outcomes. There may also be exposure variability and medication discontinuation might vary. Obesity medication use might vary by dosage, adherence, and duration, which could complicate the exposure variable. So we are going to collect detailed medication data at baseline, and we also are going to collect semi-annual follow-up data, very brief survey on obesity medication use to understand how that variable varies and conduct sensitivity analyses on that. So what are the implications and future directions? This K has the potential to advance family-centered pediatric obesity prevention and inform the broader impact of adult pharmacologic obesity treatment. And upon completion of AIM-1, we will have novel data on how parent obesity medication use relates to parent and child health behaviors, which are key factors that shape pediatric obesity. Through AIM-2, we'll identify behavioral mechanisms and contextual factors that influence household food environments. And in AIM-3, we'll generate preliminary evidence on whether parental obesity medication use is associated with improvements in child weight status and cardiometabolic outcomes. All of this will lay the foundation for a future R34 to develop and test and pilot test a scalable intervention to support parents during this critical time of adult obesity medication treatment and influencing the family. And lastly, I just wanted to share some of my career development goals that go with this K01 submission. But my hope is that these skills and goals will help me gain the necessary knowledge to lead interdisciplinary intervention research at the intersection of pharmacologic and behavioral obesity treatment. And so my first goal is to gain training in the ORBIT model, which is the obesity-related behavioral intervention trial model for the development of behavioral interventions. Secondly, I'm hoping to gain understanding of the clinical and real-world use of obesity medications, given my background has been primarily in behavioral interventions for obesity. Third, I'd like to gain proficiency in the gold standard tools for child diet and home food environment. And lastly, I want to learn how to build an electronic health record-based cohort model, learn how to extract data, and then do advanced statistical analyses with this real-world source of data. Lastly, I'd like to thank my mentorship team. The first two and the last two are from Nemours, a fantastic team. The first two are investigators at CHDS, Dr. Fideli and Fan. And Dr. Fan is also the head of Nemours Healthy Weight Clinic. Tim Bunnell is the head of the Biomedical Research Informatics team, and Dr. Camille Arista is the biostatistician for our CHDS team. Lastly, Ashley Skinner is a leading researcher in obesity, pediatric obesity, and she was my mentor at Duke. And lastly, I'd like to acknowledge my mentors at Nemours, Dr. Fideli and Patton, the K01 mentorship team, and lastly, the GIN writing group for their support. Thank you.